on the idea of why we collectively chose emergency medicine. That will lead us into a discussion of what elements of physician-patient interaction lead to satisfaction. Why is the anonymous physician at risk, and how can I improve patient satisfaction and outcomes? So most of my colleagues and myself picked emergency medicine because we wanted to do emergency care, which accounts for approximately 50% of what I actually do, right? Half the time I'm in the pods where there are really sick patients. Half the time I'm in the vertical unit where there could be really sick patients, depending on how bad the triage is. But mostly these people are going home and aren't sick. Okay. We like the idea that we can make immediate, we're capable of making immediate decisions. That's another characteristic of being an emergency doctor. You make up your mind right away. You don't go into a back room and discuss this, search the internet, go on up to date, come back 3 hours and look 3 hours later and look like an expert, which I find my intensive care colleagues do quite often. But I'm not sure I wanted this, but it's a horizontal specialty. We know more or less a little to moderate amount about everything. That's what we aim to do. It's impossible to know everything about everything. So you try and limit yourself, especially when you're preparing for the Royal College exam, right? It's so easy to go down the rabbit hole. Keep on learning really interesting stuff. Before you know it, all you know is hemonc. That won't get you very far. The hours are predictable. I mean, when your shift is over, you go home, right? You're not on, well, we are on call actually, but we're not on call after we've worked. There is an on-call schedule at the Jewish. Is there an on-call schedule here? The patient interactions are episodic and seemingly final. No long-term follow-up, which is a problem. I like to know what happened to my patients. So, I'll open their charts a day or two later. And if I can remember who it was I was interested in, I'll look them up. And there's anonymity, which I don't think is a good thing, which is the whole topic of my my discussion here with you guys. It is a characteristic of emergency doctors. Okay, before I get into that, attributes of high levels of satisfaction per the patient. They like to know about waiting times, and they'd like to have them very short, obviously, but at least they'd like to know how long, which you can never tell them. How long is it going to be? Well, it depends on how sick the next patient comes in. You may be deferred all night. They don't seem to understand that, but we try and explain that. They're always interested in the facilities, how clean, whether there are pillows. We never have pillows. Blankets, the beds are terribly uncomfortable. They're very interested in interpersonal relationship. How did people treat them? Were you polite and answer their questions and empathetic? Extremely important. They want to know what's going on. They want to have explanations of what's going on, what the tests mean. Why are we doing these tests? What do you think eventually is wrong with me? And what's my prognosis? Long, detailed explanations in their language is very important to them saying this was a good experience. Strangely enough, I added this because I think it's important, but accuracy of diagnosis and treatment doesn't come up big in the description of what leads to a satisfactory visit to emerge. Isn't that ironic? I mean, the most important thing for me, I try and be nice, but really can't control the lack of pillows. And another thing that really doesn't come up often in their discussion is follow-up, which I think is extremely important. Okay, so who am I talking about? I'm not talking about the pods. I'm not talking, my pods are where the sickest people are triaged with an expectation that they're going to either die or be admitted. That's the pods, you know? I love working in the pods. I don't get to discharge anybody, which is a very uncomfortable feeling for me. Don't like sending people home. Feel much more comfortable admitting them to hospital or signing their death certificate. I love that. That's really. I don't understand you guys. When I say I love sick people, and I tell this to the patient, and I tell it to you, and you look at me as though I'm crazy. You just don't recognize this as part of your own makeup. You do like sick people. That's why you went into emergency medicine. You're not there for preventive care. You're not GPs. You like. Okay. Okay, so I'm not talking about those people in the pods. I'm talking about the ones in the upright zone, the ones that are likely going to go home, that I'm going to discharge. And I have to do about 50% of my time in that RAS blue area, where most of these patients are not particularly ill, as I say, unless they've been mistriaged. And that's an important skill, to identify a mistriaged patient and identify their back pain as an abdominal aortic aneurysm. That's a very important skill, which you can be lulled into not using in the RAS blue unit. But the point is, these are people who are going to go home. They need to understand their diagnoses or lack of diagnoses, because most of the time, I don't know what's the matter with them, which for me, is death in the soul. I told you, I like sick people, and I'm going to tell this person, you're not sick. Oh, do I ever hate that? And I tell them that. I'm so sorry. Why are you sorry, doctor? I can't find anything wrong with you. And then they give me the look, what? It's a bad news. It is for me. You came in here with expectations, and we have failed you. So what are the characteristics of these people? They're going home. They're not going to be supervised, obviously. I haven't admitted them to hospital. Unless their mother's there, I can't depend on anybody to follow my discharge advice. As the last MD to see them, you are responsible for them. I know you thought you'd go into emergency medicine and say goodbye to long-term care and follow-up. I'm sorry, this is not true. If 50% of your patients, at least, it's way more than that. I'll see 20 patients in the pods. I'll see 40 in the for a particular day in RAS. I'm seeing way more patients that I do have responsibility for. And we've never acknowledged that these people going home are yours. Anyone looking at their chart will say, you're Dr. Dankoff's patient. Who? Getting? Who? Who's Dr. Dankoff? Right. So, as I say, most of these patients, I don't know what's the matter with them, which is very disturbing for me. And as the bottom line there, I feel the most discomfort about managing these patients than I do anybody in the pods. I'm good at resuscitation. I mean, I'm good at taking care of sick people. You just wait. You are too. All you have to do is look up the diagnosis and up to date. I know he's got this. I look it up. I give him the treatment. It's fantastic. There is no treatment for XXX NYD. It's not in up to date. So that's who I'm talking about. You got it? The ones I'm sending home. And here's the main teaching point I wanted to get to. Your responsibility for these patients continues as they walk out the door. And being anonymous is very bad. Who do you associate with anonymity? No one's talking. Good. So I'll continue. Anonymity, I associate with malfactors, people who want to do bad things to you. They want to remain anonymous. The other main group of anonymous people are people who basically aren't making an impact at all, bad or good. But, you know, when you want to have your appendix removed, you want to know who your surgeon's going to be. Unless it's an emergency. I picked up the wrong example. Emergency appendixes are not elective. No, you're going to have an elective gallbladder removal. I want Dr. Fraser. Shannon Fraser. Great hands. I'm going to say I want Shannon Fraser. I know her. I know she's good. I put down as an example of anonymous professionals, which are an exception, pilots. I mean, you don't go on your airplane. It's an elective thing. You're going to Florida or somewhere, and you're electively going to Florida. You can choose who your pilot is, right? No. You know, you get on the airplane with the expectation that all pilots basically can fly an airplane, or the airplane flies itself, except under extremely rare circumstances when you have to be skilled. Extremely rare, we hope, right? You know, we're always compared to the airline industry, and it's extremely unfair to do so. I'm not like a pilot. Our relative jobs are entirely different. I have uncertainty from the moment I walk through the door. That shouldn't be the case for your pilot, right? Okay, so enough of the airline healthcare comparisons. They're ridiculous, and pilots are an extremely good example of that. Who's that guy who keeps on comparing us to airlines? Atul, whatever. You guys know? He writes extensively about how we should be more like pilots. Take away the freedom of action of doctors, make us all follow protocols. I don't want to get into that, but the point is, I'm being treated, or at least I am evoking the same kind of privilege. You don't need to know who I am, which I don't think is correct. I do introduce myself as I walk in the room, though, but no one, do you ever remember on meeting any of you guys, you say your name, I have no clue who you are 5 seconds later. Okay, that might just be me, but there are only 2 people in this room I can name, although I've met quite a few of them. So, I give, can I go back? If I click again, will I be able to go back? How do I go back? What?
Left arrow, go with the arrows. Yeah.
So I give them my card. When I send a patient home from the RAS Blue unit, I give them my card, which has my contact information on it. You should see their faces. I mean, up until then, they thought this is the same old story. I'm being abandoned without a diagnosis. Because the other thing is, many of these people in upright are coming here for their 4th opinion, right? Why are my teeth itchy? I mean, I've seen like 20 doctors. Can you tell me why my teeth are itchy? And I'm going to take it seriously. I'm going to find out, if I can, why his goddamn teeth are itchy. And when I fail, I'm always uncertain. What have I missed? Maybe it's vitamin C deficiency. That just came to me. Okay, so here's my card. Because up until then, I've told you I don't know what's the matter with you. And you got this, the face, you know, I'm being abandoned again. Then I give them my card. Wow. I can call this guy if my teeth start to fall out. That's what he told me. Dr. Dankoff. And I want to know if his teeth are falling out. I mean, I missed that. I mean, it only came to me later, but doctor, the email says, my teeth are now falling out. Shit, that's very specific. I can look that up. Not just itchy, but falling out. Vitamin C deficiency, #1 diagnosis. Email him back. Come see me immediately. can you get vitamin C levels? But at any rate, everyone agrees there's a vitamin C deficiency. Isn't that wonderful? That feeling of satisfaction. Okay. How do I go back? Okay. When you give them your card, you can abbreviate the discharge instructions. Isn't that wonderful? I mean, I don't have to go through the litany of things that could happen to this person as they're going home with their pneumonia. I can just say, and if you start coughing up blood, call me, or any other untoward events. Don't hold your hand up, just yell.
I'm gonna yell it out. How often are you impacted?
That is a very good question, and it's the first one everyone ever asked me. Do people abuse the privilege? They don't. Okay, maybe 1 in 200, 300 calls me 6 months later and says, my mother needs to see an obstetrician. Can you arrange that? My mother needs an obstetrician. My mother needs a gynecologist. Can you? And then I'll write back. I'll write back. No, that's not appropriate. I'll reiterate the definition of emergency doctor. That's not my domain. You're on your own for that. And they, that's reasonable. I'm going to elaborate on that in a few minutes, but the short answer is they don't abuse the privilege. And you've alleviated anxiety about being abandoned. You should see the expression on their face when they get my card. I mean, that's wonderful, doctor. You do care about me. Well, they don't say that, but that's what you're communicating to them. Okay, this is an important thing. Yell.
I don't want to interrupt you. And but what if like they should be going back to the hospital? They're like, oh, I'm gonna email him first. Then you don't have time to get back to them in the next like 24 hours.
That's another extremely good question, and I'll get back to that in one of the slides. But that's very good. That's a very important point you're bringing up. Let me finish with this first, though. Stop yelling out, okay? Being honest about your diagnosis is what you're telling them with the card. You're basically saying, I don't know what's the matter with you because you said that, but I may have missed something. I want you to call me if something bad happens. And when I usually use that term, don't hesitate to use my email if something untoward happens. Wow. No one's ever said that to them from an emergency doctor. And then I usually, if they seem receptive, I'll go into my spiel about how I love sick people, which gets that look all the time. I love sick people. Really? Yeah, of course. What do you think? And I can't go on all day long telling people I don't know what's the matter with them. I want to tell people bad news. And you're doing it too. You want to tell people bad news. You've asked for an x-ray of the guy's hip. You want to tell me you're not disappointed when they don't have a fracture? Oh, laugh it up. Laugh it up. You're just as sick as me. And when you do have a diagnosis, this just proves your confidence in it. You have X. I'm sure of that. Here's my card just in case I'm wrong. Accountability, that's built in. And they sometimes email you with, hi, doctor, you're such a wonderful person. I'm feeling so much better. Where can I send a gift? I'd like to give some money in recognition of your abilities to the hospital. That's nice. Rare. Oh, but I invite them to do that. Oh, and you can send me an email saying how much better you are. I'll do that. It depends on my interaction with the person, how much I can go off into these. This takes about a half an hour to make at Bureau en Gros. If this terrifies you, giving people your card, I know I'm not talking to attendings here. I hope
There are some at home.
attendings find this terrifying. Every time I discuss this with my colleagues, they say, oh, no, I can't do that. I mean, I'm a mother. I have 3 kids at home. I have to go home. I'm not going to start answering emails from patients. When I'm finished, I'm finished. I just want to, I tell them, come back to the hospital. Okay, so think about that. You've incorrectly prognosticated this patient is sicker than you thought he was, ends up coming back to the hospital. Okay, he's mistriaged again, like usual, and waits another 8 hours to be seen on the second visit back. I mean, it's just not fair. When you tell people come back if you're not feeling well, they shouldn't have to wait another 8 hours or 12 hours to be seen. So they email me and I say, okay, if this is appropriate, I'm working either at 4 o'clock this afternoon or 7 o'clock tomorrow, or even 2 days from now. If it sounds like they can wait to see you, great. I mean, this is a very fast evaluation. I'm not abusing the system. They come in, they ask for me, I see them in 30 seconds, gone. Or, oh shit, this is really bad. I'm gonna have to admit it. But it's quick. I know all the history. Rarely I'll defer it to a colleague and I'll give them a heads up, this guy's coming back. This is all very rare. But you smooth the rails on this situation. Okay. What other objections do they have, my colleagues? I can't understand why they want to remain anonymous, because when something bad happens and they don't know who you were, they go to St. Mary's Hospital. So you saw a doctor at the Jewish General. Do you remember who he was? I think his name was Koff or something. Oh, Dankoff. Yeah, he's an idiot, real idiot. So, you know, he missed this and that. And if I miss something, I don't want anyone else to know about it. Okay, maybe that's just me. Boy, you guys are really in for an eye-opening when you go into practice. I don't want other people to know I missed that. I want them to come back and see me. Shout. Okay. Okay.
For example, you say, I told the patient to come back at Jan, since you're up, passed away home. You get a document that in the chart saying, I told him to go up.
That happened to me. Did that happen to you? It happened to me. And I'll get into that in a second too. Believe me, these are all great questions. I'm going to come back to them. If I don't, re-ask me. So this goes even beyond telling people your follow-up information. Okay, American system of healthcare and Canadian system of healthcare are completely different. But in the Kaiser Permanente, all the patients that are being discharged, all patients that are coming in, you never know who's going to be discharged, register with their email. And if they did go home, they're all followed up within 48 hours to make sure, did you buy your antibiotics? Are you feeling better? They love that. The rare times I do that, you know, like I want to know, really, how is this guy doing? I'll call them and the French word is they capote. They really, they love that. When you call them 48 hours later or a week later, are you feeling better? What can I do for you? You know, that kind of thing. Okay. So, and there's one of my colleagues who does this. I saw her 2 days ago. She calls our questionable discharges. And she's the last person on earth I would have thought to do this. And she uses her little girl voice. I can't do it. Because normally it's a different voice. But on the phone, she's, and they love it. I couldn't believe she was doing this. All right, so here are the caveats. You have to respond to emails in an appropriate manner. And if they're sending you an email, hi, doctor, I'm vomiting blood and paramedics, that's not right. I feel very bad. I've been sick all night. If you tell them something inappropriate in your email, that'll come back to bite you. So you have to appropriately respond to an email. I got this email from a lady I'd seen a week earlier with I thought an intrauterine gestation at 16 weeks. Everything looked fine. She'd had 4 C-sections prior to this gestation. That should have rang a bell. And she emailed me, or somebody emailed me, I don't know who's writing this because it was a very poor English, that she's been sick all night. And I told her, I'm going to be in the emerge at 4 o'clock, come see me. 11 o'clock that night, I remember, this woman's sick, she's supposed to have come back to see me. So I called the home and there's no answer. Something's fishy here. I called next day, her husband answered the phone and said, she's dead. No, he emailed me the next day, she's dead with a weepy face. This is a joke, right? Weepy face? Seriously? So then I called. Yeah, she's dead. She ruptured her uterus at 17 weeks. I think it was a scarf topic. Anyway, she went into a peripheral hospital. I heard about all the details because they were doing CPR on her using a TEE, which made the emergency community very interested in, using TEE to do CPR. She got to the OR, found an abdomen full of blood, and she didn't make it. So I learned from that, when somebody says, I'm really sick, you don't defer it to the 4 o'clock appointment. You say, go to the emergency immediately. Okay. Oh, documentation's a problem. I may be in my car when I get an email, and you have to respond to these emails in a timely manner. Later on, you've got to document this in the chart. Answer your question?
That's the privilege of not being on call to being on call 24/7.
But I told you, they don't abuse the privilege. It's rare. Since I've been preparing for this talk, I've given out the cards way more commonly. Now it's maybe 15 cards a day. And so that's way more than I used to, because I used to be very selective. I'd look at the guy and say, this guy's crazy. Itchy teeth. What the hell is that? I do not want to know about his itchy teeth.
Question again with the documentation. So like anytime that a patient gets in touch with you, like are you later going into the chart and documenting like on central, like finding this person?
No, but I should. I think you should.
So you're doing on vacation.
Okay, so my email, I make sure that my email says I will not be able to respond. You have to do that. You have to remember, if you're not available, that email says I'm not reading these emails, or at least I am, but I'm not responding. I don't know about this confidentiality rules. I rarely release this kind of information. Yada yada yada. You got GC or something on an email. That hasn't come up yet, but that might be questionable. I'm not even sure. I wrote to our IT department. They never answered me back. I'm not sure. Is the SSS email more secure than McGill? You're all shaking your head. Why do you know this? Yeah, I got that too. I was told I have to use my SSS all the time. But McGill has a twofold identification mechanism. I didn't understand a word you said. The SSSS? It only works on Outlook?
Yeah.
What's a server? I'm fuzzy on servers.
Well, yeah, I don't know.
Okay.
We don't know more than you about.
What
it.
was your question? What was your question? You had a question.
It got,
Sophie.
it got answered.
Oh. My daughter says it won't work in peds. That they'll view you as their GP and they'll email you for every single thing. I don't know.
Always every time.
I don't know. I think it's my lack of charisma. I can't get any of my colleagues to do it. Everyone had brought this topic up, and they'll acknowledge some of this is true, but they don't want to do it. I'm the only one that gives up my card, and I've come to medical legal attention because of it. And McCarthy Tetro are defenders. I had an opportunity to speak to a lawyer, and they said, "You're the guy who hands out his card." Fantastic. They think it's a great idea. I think accountability is such a basic thing in being a doctor, and that being anonymous is hurtful. I'm not a pilot.
Did you know CMU? Because it would be interesting to kind of have their take on exactly what documentation is saying. Because there's still this.
There is a document about this, about that you can look at the CMPA. It has to do with confidentiality. But that's all they really talk about is confidentiality. But I've never actually discussed it with anybody there. Are you going to start handing out your card?
I call people.
You do next day, because you're a pediatrician.
Well, I do for children, but if I'm not sure, I either go on Oasis or I call people, and I mostly do it because it makes me feel good. Because people are so, like you said, they're so grateful. They're like, "Oh my God, thanks for calling. This is so kind." I'm like, "You're the only person that thanks me in a week." Like, it's like very nice. So I do it to like get thank you.
That's true.
When you call.
That's true. I mean, it's so satisfying. Okay, if there are no other questions.
So in the chat, there's Dr. Gutman, who says he also gives out Jerry's card. And there is John Wang who has a question, but I'll ask him to ask it, but maybe we won't hear it on the speakers here, so we'll try to find a way to do that. So go ahead.
Go ahead. All right. So thanks for the talk, Jerry. I don't think I'm going to go out and hit up the printer to print 1,000 cards, but what I do instead is I print out a copy of my evolution notes and I hand it to the patient on the way out the door together with some labs. Feel it makes a nice souvenir. I point out my name at the bottom of the page, and I feel like it gets the same point across without having to deal with the follow-up baggage, the warm and fuzzies without the email or the call in the middle of the night for PRNs.
Anybody want to respond? I mean, I've already given my opinion on this.
I have another question, but not related to this. I was wondering, like, in a typical month when you're working with a full-time, say 16 shifts a month, I don't know. How many emails do you say you're actually responding to, or phone calls actually?
Well, I respond to all of them. I mean, I acknowledge that I've got an email from everybody. It's maybe now that I'm increasingly giving out those follow-up cards, it's maybe once, twice a week. It's not an onerous task.
There's Dr. Nana who has a question.
Hi, Jerry. I have two comments. One, I love your talk, but you won't like the reason I love your talk. So I have so many issues, counter arguments to your philosophy of what you just described, which is good actually. That's what a good talk should do is put rocks in your shoe and make you challenge your own beliefs. And I will tell you, probably, you know what, we should set up a debate at one point, because there isn't enough time for me to refute all of your argument, your sort of reasoning. So I will say that I completely disagree with your philosophy about, well, almost completely disagree with your philosophy about anonymity and well, not even that, but just how you deal with things like what you just described. Number one. Number two is, I wonder, and I have this question for you, and be honest. If you were in the beginning of your career, like this is like year 2 of your career, would you have the same philosophy? And be honest. Because I have a feeling, and I've seen this from myself as well, that as we're nearing our career, and I'm in the same boat, maybe not as close as you are, but I'm in the same boat as you are. We start becoming very, very idealistic, and we start becoming like we don't see we forget all the what we've been through, and we start saying, you know, maybe we should do it this way and that way, and that's good. That's wisdom that comes in. But the reality of what we're up against, I think we forget. And so anyways, that's my one-liner. I love to talk because of what I just said. Thanks, Jerry.
Nowhere near the end of my career. Any other comments?
There's nothing more than that. No.
All right, thank you very much.
I'm just gonna log you out, Antoine. Antoine, I'm just gonna log you out.
Yeah. Go ahead.
Je le vois pas. Yeah, because there's a little icon here. Just prevent while I go visit. We're good? Hi, everybody. My name is Paola. I'm one of the CCF PEMs, and today we're going to talk about the validity of direct fundoscopy. I hope you get the quote. Oops. Okay. So first, I have no financial conflicts of interest. We're going to review the technique of DF. We're going to explore the accuracy and validity of DF in the ER setting. And we're going to try and understand the limitations of DF and try to circumvent these issues. This is just a brief outline of what we're going to go through. So we will discuss POCUS at some point, okay? So when was the last time that any of you performed fundoscopy on a patient? I'm really curious. Kath. Okay. Yeah. Okay. Any other answers? Audrey?
2 days.
2 days ago?
Yeah.
Okay.
Well, I think the point you're making is we're not really good at it, and we agree with you.
We're gonna go to that. We're gonna go to that.
Not true.
Out of curiosity, has like some people not used it in the last year? Raise of hands. Don't worry, you're not alone. In the last 2 years? Yeah, exactly.
Dr. Dankoff, you did it.
Well, during COVID, I didn't want to get too close to people. No, I didn't do it during COVID, but I do it in, when it's necessary.
So in your practice, when do you perform fundoscopy? So we said kind of when you have suspicion for papilloedema. Any others? That's pretty much it. Very well. And are you confident about your skills?
Hell no.
Hell no. Okay. So a little historical note because history is important. So in 1851, von Helmholtz created the first ophthalmoscope. 3 years later, Ulrich started to put a candle light attached to the ophthalmoscope because before it was, candle and ophthalmoscope trying to go to actually see the eye. And then over the next years, there's changes in the mirrors, tiltable mirrors, wider mirrors that help you see better. At some point, it's an oil lamp instead of a candlestick. And at some point, in 1885, we actually put an electric bulb essentially for our light source. These are just a few pictures of the first ones that got invented. So quite different from what we now have. And so we'll go over a little bit the traditional indications. So fundoscopic exam is a routine part of every doctor's exam of the eye, not just the ophthalmologist. So acute vision loss, visual disturbance, ICP screening, headache, neurological deficits, severe hypertension, head injuries in infants, and evaluation for endocarditis. So those are all times that theoretically, as per Tintinelli and Schneiderman from 1990, you should be doing DF. So in terms of the techniques, so you want to be hopefully in a dark room. You ask the patient to look a point afar and fixate on it. You adjust your ophthalmoscope to your eye prescription, and then you try to get your right hand with right eye to go on the right eye of the patient, and same thing on the left. And you want to actually move as a single unit. So you're going to go like this. You don't have to adjust all the time. 15 degrees off center towards the nose, dive into the red reflex, look around, and hopefully identify your structures of interest. Obviously, these are all panoptic fundoscopy images. So PICO question, apologies for colorblind people. Compared to other means of fundus visualization, is direct fundoscopy performed by emergency physicians accurate? So we're going to try to answer that. To do so, essentially, I searched on PubMed. I did both a search with only keywords and then a mesh term with keywords. Unfortunately, there was not a lot of literature actually telling us what we think is true. Essentially, I had to review the references of the articles that I found interesting on it to essentially end up with a scoping review. So overall, not much hard evidence, many conclusions. The ability to recognize papilloedema by routine DF alone, particularly when we have non-dilated pupils, is limited. Panoptic is more reliable. And although the usefulness of viewing the ocular fundus is well recognized, ophthalmoscopy is infrequently and poorly performed by non-ophthalmologist physicians. So again, why are we using it? So essentially, we're going to go through one study that directly answers the PICO question, 2 studies, so essentially 2 phases of a 3-phase study that indirectly answer the question, One study that compares direct ophthalmoscopy, so whether it be panoptic or DF, to essentially non-mediatric ocular fundus photography. And one study essentially does the third phase of the three-phase study that maybe gives us a bit of information of why it might not be valid. So this is the first study that directly answers the question. So in this study, which was very small, the article actually fits on 3 pages. They looked at papilloedema and how well we were able to recognize it. So essentially it was 36 emergency physicians within the 2 first years of their practice. Undilated pupils, brightly lit room, 90 seconds to do the exam. So kind of what you'll find in the actual image setting. Conclusion was the panoptic is more sensitive and specific compared to DF. So essentially using the panoptic over DF doubled their sensitivity and specificity. So that's quite good. In terms of the quality of this study, well, unspecified if the EPs were similar, actually, the groups. So do they have the same interests? Are they both, 5-year versus a kind of a family medicine +1 program, essentially? Also knowing that this was not performed here. Unspecified patient characteristics, the randomization process, although they state it was randomized, we don't know at all how it was performed. And it was entailed that the EPs were blinded, to which they were examining abnormal versus normal, but it's actually not stated, and small sample size. Essentially, they were examining 18 patients. So indirectly answering this question of is it actually accurate is the first phase of this 3-phase study. So essentially, they looked at emergency physicians from a university hospital. They wanted to detect the rate of fundoscopic findings relevant in the acute care setting. So essentially, is it actually going to change my management and the disposition? Overall, 350 patients were enrolled. So by that, they meant that fundoscopy was actually indicated. And EPs did their assessment to their discretion. They, however, knew that the study was happening in the emerge. And then photographs were taken by NPs, so by non-mediatic ocular fundus photography. And afterwards, these photographs were actually interpreted by 2 neuro-ophthalmologists. Most of the photographs that were taken by NPs were actually high quality. Only 3% had no diagnostic value. And 44 out of those 350 patients who had indications to do DF had abnormal findings. Overall, the emergency physicians performed DF in 48 out of those 350 patients. Again, they knew that the study was happening in the emerge. 46 out of those 48 were documented as normal. And there were 2 out of those 48 that were documented as abnormal. They also knew that these patients had abnormal findings because it was already known in their charts. Essentially, most findings were identifiable on the photographs. And of note, essentially, every finding that was abnormal, that was new, was missed by emergency physicians. So in terms of the quality of the study, quite a large sample size of patients. All patients are accounted for in the analysis. Unspecified sample size of the emergency physicians. Are we talking about 5 that were in this study, or are we talking about 40? And limited characteristics. These were physicians that were attendings. We don't know more in terms of their experience. The study was otherwise kind of well done in terms of clear inclusion, clear exclusion criteria, protocol clearly stated, primary outcome determined. 2 ophthalmologists agreeing by consensus on the findings. Okay, it's only daytime hours, it's only weekdays. And otherwise, again, hot turn effect was present. So essentially, 1 out of 7 patients were actually examined for DF, but they took a look at 100 patients before they started the study, to which fundoscopy was indicated, and only 4% had DF that performed. So that's quite a change. And patients that might have looked too sick were excluded. Then they performed the second phase of the study where they wanted to see kind of the accuracy of the photograph. So are emergency physicians able to interpret when they have the perfect image in front of them? So essentially the emergency physicians were notified at that point that there was a photograph that they could review in the file. And it's curious. Emergency physicians reviewed only 239 out of 350. It's like, oh, I got a CT, but I'm not taking a look at it. So EPs judged that the photographs were helpful in about half of those cases. And essentially 16 out of 35 abnormal findings were identified by the emergency physicians on the photographs. 8 out of those 35 were not reviewed by the emergency physician. So again, you're thinking about, okay, how what's my pretest probability and how is my image going to tell me anything? And essentially 7, we weren't sure. Okay, I'm normal, but okay, I'm not sure. And essentially in terms of the opposite, so we're likely abnormal but unsure, but we're actually normal, and it was poor quality images. So they are forgiven for that. It's the same group, so pretty much the same quality as before, but also we wonder, were the emergency physicians kind of honest in their declaration in the study? Okay, I'm putting my diagnosis before and my management before, and I'm doing it afterwards as well. Has it really changed anything? Then we have another study that was performed in Australia, and essentially they wanted to see how photography essentially helps us manage our patients. So we had 52 emergency physicians. So that ranged from a first-year intern that was considered as an emergency physician to people who had 30 years of experience. They all underwent a 30-minute lecture to review direct ophthalmoscopy, whether it be DF or panoptic. And then the emergency physicians had the liberty of using their preferred method of choice. And in terms of direct ophthalmoscopy, again, sensitivity was 0%, specificity was 59%. That raises some questions, I would say. NMOF photography led to management changes in about 52 out of those 133 patients. So about 39%, 34 were escalations of care, 18 were de-escalation of care. And essentially that tells us, without like a formal, training to how to interpret the pictures, we know how to use DF. Okay, we've done a module on that, but they were actually able to improve their sensitivity and specificity, which is quite good. In terms of that study, it was nice because it was a crossover study. So that means essentially it was the same group of emergency physicians doing the DO and DF and then interpreting the photography. Again, clear inclusion, exclusion criteria, relatively large number of emergency physicians. We're talking about 50, medium-sized number of patients, okay, 133. Of note, their power calculation were based on 140 patients, so we're just a little bit below that. Protocol clearly stated, again, 2 ophthalmologists reviewing the images to tell us really accurately if there are findings or not. And again, this was daytime hours and weekday hours only. This last study I included just to tell us maybe a bit why we're not so good at direct ophthalmoscopy, whether it be DF or panoptic. So essentially, they looked at emergency physicians that would complete a training module about, how to interpret images and all of that. And essentially, 12 out of those 14 emergency physicians actually completed the module. So there were 2 that did not complete it, but answered the questions of the pretest. Okay, it took about 30 minutes for them to do the actual module, and essentially pretest training was 65%, post-test 71%. So we're not improving by a lot. Trained emergency physicians identified correctly abnormals as abnormals 67% of the time before, and then 57% of the time after. Untrained physicians, it's about 50. Trained emergency physicians, again, the normal as normal, about 80%, 84 on the post, and untrained 79%. So essentially makes no difference. You could question, is it the module that was the problem? Is it that it was too short, the quality of it? But still, it kind of brings out some questions. Again, it's the same group as the third phase. It's relatively small sample size in this case, 14 emergency physicians. We don't know a lot about them, but clear inclusion criteria, clear exclusion, protocol clearly stated, primary outcome, 2 neuro ophthalmologists again, and means of analysis clearly stated. about POCUS in terms of helping us to identify papilloedema, essentially. So on CIS, so essentially you go 3 millimeters behind. Perfect. So essentially you want to go just 3 millimeters behind because that's where the nerve, the globus of the nerve is. And essentially that's where the pressure changes is going to affect most of the nerve. So that's why we could go there. And then you want to see essentially how wide this area is. And essentially the upper limit of normal should be 5 millimeters in adults and 4 millimeters in infants. So back in 2020, there was this study that was performed to see how residents actually do on CIS. And again, the limitation of this is that this is only for papilloedema. So if you're looking at searching for other findings, so whether it be kind of these cotton wool spots, the flame hemorrhages and all that, well, unfortunately, that's not going to help. So overall, 206 patients were enrolled, 55 emergency medicine residents, so PGY1 to PGY4, and essentially 46% sensitivity and 87% specificity. So again, if you think about the numbers about DF and panoptic, this is not too bad. Overall, DF is challenging. Fundoscopic examination is probably underperformed. I'm quite impressed by our group. But essentially, it should be performed, as per the textbook for every neurodeficit, for every visual disturbance, headache, ICP, severe hypertension. The exam is as good as your skills. And unfortunately, at least those emergency physicians were not very good at it. Panoptic is better than DF. NMOF is even better. If your question is papilloedema, use ultrasound. And if you're concerned, honestly, just call off though. Just 2 remarks. NMOF is not accessible at McGill in the emergency department, so we cannot rely on that. Bottom line, use your ultrasound. Again, call your ophthalmologist. And having spoken to a few ophthalmologists about this, NMOF is great, but it does not replace the dilated exam. It complements it. So essentially, it gives them a better idea of but you still have to do your dilated exam. Any questions? Yes.
Was there anything, I mean, when a patient goes to the ophthalmologist, any ophthalmologist I spoke to, they're like, yeah, what's that sticky thing? I haven't used one of those in 30 years. Because they don't use direct fundoscopy at all. They use indirect.
Yeah.
Are ophthalmologists very good at direct fundoscopy?
I mean, if we take a look a little bit.
It seems like most of it comparing to the photograph.
So I don't remember, I didn't look specifically for that. But if you take a look at a few things here, let me see, I missed the slide. So, 6 out of 33 findings were identified by the ophthalmology consultation. So was this in the emerge where they did panoptic? You could question that. Is it that when they had the photographs, that it's not that because the photographs were done afterwards and reviewed afterwards. So presumably they're not much more amazing than we are in terms of that for DF and panoptic.
Like in the very rare occasion that ophthalmology shows up in ER, they
Yeah.
usually bring their little briefcase.
Exactly.
And I don't know if you've ever done indirect endoscopy.
No.
Oh my God, you can actually see one. Like, it works really well.
Yeah.
Run, but we children, and there were 3 cases that were for understanding for papilloedema by the ophthalmologist. We went towards the ophthalmologist said that papilloedema was for. We were seeing them, and neurologists who talked about it, and then scans, like the children had scans, and the neurologist came down and she was like, "You have to do something about this because that's ridiculously he's sending us papilloedema every time I come and see." And I checked for myself, and there's no papilloedema. And I'm like, okay, but like ophthalmology says there's papilloedema, who am I to say that's not right? And then, and we keep on solving for just like, it took a long time because you have a scan and ask the neurology saw it, and neurology said, what is the papilloedema? So you waited for nothing, and I don't have to teach it again.
Yeah.
And then ophthalmology was supposed to follow up, but then even they disagreed, and neurology very constantly disagree with ophthalmology,
Mhm.
despite the fact that people do think the direct.
Yeah.
So I'm like,
And
so, yeah.
I'd have to say I share the same experience. Like I remember being, at another grand rounds in Toronto, and it was neurology speaking with ophthalmology, and ophthalmology was saying, "Why are you even doing DF? Like, what's the point? You're really bad at it. Please don't do it. Like your findings are unreliable. Skip over it, and do something that you're actually good at." Like this was literally how the conversation went. And they were saying, like, if you are concerned, please send us to ophthalmology and we will do our testing properly and have actual answers instead of scanning and doing all the a lumbar puncture to see is the opening pressure high or anything.
Puncture, right, and the lumbar puncture, and measure the pressure, which is normal, so normal pressure, normal scan.
Yeah.
And I spoke to ophthalmology because I didn't consult neuro right away, and I'm like, what's normal pressure, like, we got neuro, like, normal scan,
Yeah.
what are they gonna do, right? And ophthalmology, like, we still really like neuro to see them, right?
Yeah.
So, and then in the end, ophthalmology was like, okay, well, I guess we'll follow up with them, and do some other testing for autoimmune conditions and stuff like that. So.
Yeah.
I know you didn't specifically look into that, but you don't know that. In the study that you presented for focus, I'm a little bit surprised that the sensitivity of 46%, it's way better than 0.
Yeah.
Good. When you read the studies, there anything that jumped into your face and said, wow, why it was so low? Is it because it can be a delayed finding and you still can have a bit of papilloedema without it reaching the upper limit of normal? I don't.
So full disclosure, I created this talk like about a month ago. So it's not fresh in the mind necessarily. I don't remember essentially were those emergency physician residents, did they have training, formal training to do POCUS, whether it be a certification or whether it be other means. So that's one of the questions I wonder. Again, is there a delayed kind of phase? Perhaps I'm don't know enough about the pathophysiology of like when exactly it will show up. But yeah.
But I think in that probably like between 5 and 7 is a gray zone. You can't say anything about it.
Yeah.
And then above them, so I don't know what that was measured. If it was a gray zone, maybe you consider that was like, I don't know, maybe that
Exactly. Yeah.
So,
Have you spoke with the ophthalmologist of maybe, I'm just like thinking, if maybe in the future, we would be able from triage, just like with EKG, to get like retina photographs, so that we get that those patients, you see it, they go, okay, that's normal, and by then, just like with EKGs, now
Yeah.
we're more comfortable because of the volume of things, all the teaching we get. Do you think one day we'll get there, or the extra info it brings doesn't really change the game?
From what I didn't directly ask that question. However, the impression that I got was something along the lines of, well, they're going to be, in a timely fashion, sent to ophthalmology clinic the next day, receiving those photographs, and they will be reviewing them and, doing their further exams as well. I think it's a wonderful idea, that we use that in the emerge. It would at least increase our sensitivity and specificity. Exactly. But I think especially with COVID and now like implementing new things in the emerge, I think there would be a lot of time required and desire, to actually do that motivation. Aaron.
I was gonna say, I think it would be similar to almost like an ortho comparison where they actually sell mounts for the panoptic where you can put your iPhone and take pictures directly from
Yeah.
your phone. And I'd be interested to see like just like send it to an ophthalmologist and say, what do you think of this? And an hour people see tomorrow.
Yeah.
Like someone's like an expert, like you need to come in for this and your clinic. And that's when you can eventually.
Yeah.
Great talk. All right, so we'll take a break up until 10:35. All right, so we'll be back at 10:35. Thanks for talking. All right, so we're gonna resume the talks. So our next speaker is Mathieu Roux, who is one of our residents, who's gonna talk about the professional liability of the physicians here in Quebec. All right, Mathieu.
Thank you, Antoine. All right, so anybody can ask questions except Anne-Sophie, okay, because I'm a bit scared now. Okay, all right. So we'll talk a bit about the specific topic of professional liability in Quebec, which is a bit different than what is done in the rest of Canada, and also different from what is done in the United States. We don't have that much of info in the Tintinollis and Rosen, so I hope that my talk will be helpful to understand a bit what are your expectations as a physician or a resident here in Quebec. So what we're going to talk about, just a moment. All right, so we'll just do a quick overview of the Quebec legal system. We'll talk about professional liability, which is the main part of my presentation. We'll go through a vicarious liability, and if we have time at the end, I'll give a quick overview of college complaints, disciplinary hearings, and also criminal offense that can apply to physicians. All right, so just a few stats to start with. So CMPA is the organization in charge of your defense and also to pay for any damage you would have caused to patients by your fault. So just a few stats. So in 2021, there have been 4,800 college matters in which CMPA was involved, about 1,000 legal actions, so in front of a court, and also 2,000 hospital matters. In terms of patient compensation, we're talking about $1.2 billion paid over the last 5 years by the CMPA. And just for the last year, this is $276 million, and it was an increase from $70 million from the previous year. So as you know, Quebec is a bit different from the rest of Canada. We all hear that here it is civil law. We don't have common law, which is not true, actually. For most of the law domain, we use common law also. But for the private law, which is the relations between two citizens, yes, we use civil law. It just means that it is statute law that defines the rules here and not only the legal procedures. So just a few legislative jurisdictions, because we always see Canadian laws versus Quebec law. So what applies to what? So Canada is in charge of criminal law, indigenous law, refugees, migration, and military. And for Quebec, their jurisdiction is a bit more about civil law, healthcare, hospitals, labor union, and also disciplinary and professional affairs that belongs to the provincial level. So what are the different courts? So for example, if anybody complains about you at the Collège des Médecins, how this will process? Well, you'll have a disciplinary hearing, at the Collège des Médecins, which is there. You can have an appeal at the Tribunal des Professions, and then you can have revision of the decision by the Court of Quebec or Superior Court of Quebec. If you are bring at a trial because you did some professional, you made a professional fault and a patient was injured, it will go most likely at the Superior Court to start with. And then there's you can appeal at the Court of Appeal, and it can go after that at the Supreme Court of Canada. And if you're convicted for criminal offense, it can start either at the Court of Quebec or Superior Court of Quebec. If you're condemned, you have automatic right to appeal at the Court of Appeal of Quebec, and after that, it can go to the Supreme Court of Canada. All right. So in medicine, we all have seen this nice pyramid of the hierarchy of evidences. What is at the top? It is knowledge. It is systematic reviews and meta-analysis. What is at the top of the sources of law in Quebec? It is not knowledge. It is constitutional law. So what applies? We have Canadian Charter of Rights and Freedom. There's also the Quebec equivalent, which is Charte québécoise des droits et libertés de la personne. And yes, they're both relevant. They're not redundant because the Canadian Charter of Rights and Freedom only apply from a relation between a citizen and the state. Okay, so in a relationship of, for example, a patient and a the Canadian Charter does not apply. It's only the Quebec Charter that will then apply. So they are both extremely important. Below constitutional law, we have statute law. So a law that is decided by parliament members. So just a few examples, we have the Civil Code of Quebec with some very pertinent articles or sections, sorry, about consent. Also, the Medical Act is statute law. We also have regulation. So those are not decided by parliament members. They're decided by some public organisms, such as the Collège des Médecins. So the Code of Ethics of Physician is not a law, it's a regulation. So it can be changed without the consent of parliament member, but it has authority under the Medical Act and the Professional Code that are law by themselves. After that, we have case law or common law. So we have a very nice Supreme Court in Canada. We're very lucky. It's independent, very good ex-lawyers or law professor that end up there. And we always say that case law or common law is below statute law and regulation, but it's not really the case. If you look at this decision that is Carter against Attorney General of Canada, that's the decision that said that the Criminal Code of Canada that would punish medical assist in dying is against the Constitution. So then the case law or common law goes on top of statute law. Okay, so yes, judges, they're not elected, they're nominated, but when the Supreme Court of Canada says that the law goes against the Constitution, their decision now goes over statute law. And after that, we have knowledge. Okay, so the knowledge has unfortunately very low strength in a civilian or criminal trial. Okay, so every article, scientific evidence, that's very, very low authority in terms of law. All right, so let's start with the professional liability. So in other words, when a patient feels that he did something wrong and they get injured and they want to have a compensation, they will go in front of the Superior Court of Quebec and they will try to sue you. So let's see what is going to happen and what are your responsibilities towards your patients. So professional liability, there's a very, very famous court decision called Lapointe versus Hôpital de Garteur. It's from 1992, but all the main principles of professional liability were kind of set up in that decision. And it was an emergency doctor actually involved in that decision, the decision. And we'll go through it in a few slides. But something they say is that principles which govern professional liability have a long jurisprudence history, but any review of the law must begin with Article 1053 of the Civil Code of Canada and the notion of fault. So they define that there is no fault liability in Quebec, which is extremely important, and refer to the section 1053 of the Civil Code of Lower Canada that does not exist anymore. Now it's the Civil Code of Quebec. So I will ask you, because it has to be interactive, Anne, would you like to read the first two paragraphs of the Article 1457?
Every person has a duty to abide by the rules of conduct that incumbent on him according to the circumstances, usage, or law, so as not to cause injury to another. Where he is endowed with reason and fails in this duty, he is liable for any injury he causes to another by such fault, and is bound to make reparation for the injury, whether it is bodily, moral, or material in nature. He is also bound in certain cases to make reparation for injury caused to another by the act, mission, or fault of another person, or by the act of things in his custody.
All right, thank you. So in other words, you need three things to be liable in terms of civil liability. So there needs to be a fault, which is not an error. So we'll see what's the definition of a fault in a few seconds. There needs to be an injury. So a fault alone won't involve your liability. And also there needs to be a causal connection between the fault and the injury. Okay, so those are the three cornerstones of civil liability. It's a bit different in common law. They have 4 criteria. 1 and 2, they look a bit like the civilian, like at the fault, and 3 and 4, they are similar to like the injury and the causal connection, but it's not exactly the same as what we have here. And I'm far away from being an expert in common law, so I'll move on to the next slides. So as I said, we need a fault, injury, and causal link. And the 2 last sentences are extremely important. So the proof of injury is not a basis for presuming that a fault was committed, and also prove that a fault was committed does not, without more, establish the existence of a compensable injury. Okay, so you really need three of them. So fault, injury, and causation. So let's go through Lapointe versus Hôpital Le Gardeur, that famous 1992 decision. So there was a 5-year-old girl who suffered from a severe cut at the elbow. She had some arterial damage, went to Hôpital Le Gardeur, that is in Terrebonne. There's a GP that is there who's the on-call physician. The GP starts an IV drip, realized that he cannot suture the artery. So there is some arterial damage, thinks the patient is in pre-shock, does not start transfusion, it's 1992. And the physician decides to transfer the patient at Saint-Justine at a tertiary center to have the artery repaired and a possible shock to be treated over there. Unfortunately, when the patient arrived at Saint-Justine, patient is in shock. 30 minutes after, there's a cardiac arrest with cerebral anoxia. And it's always nice to look at the timelines and see how things were in 1992. So the patient arrived at 4:15 at Terrebonne, and less than 1 hour, 1 hour late, within 1 hour, the patient was triaged, assessed by the physician, and there was a transfer organized, and the ambulance for the transfer arrived, which is great. All of that within 1 hour. 30 minutes later, patient is at Saint-Justine, cardiac arrest at 18:30, and then weeks of coma. Finally, the physician was not culpable, was not convicted for professional liability, and we'll see why. So those are a few decisions that the Supreme Court of Canada have written in that decision. So as I said, we import the principles of ordinary civil liability. The obligation that we have as physician or residents is an obligation of means, not an obligation of results. That's important. And what is the obligation of means? How is it assessed? We will be compared to a prudent and diligent doctor placed in same circumstances. You're not compared to the best, not to the lowest of your class, just to the prudent and diligent doctor within the same circumstances. Also, the assessment is done what is called in abstracto. So they're not going to look at, have you done your best that day? That doesn't matter, the judge. They will look at how are you compared to that prudent and diligent doctor, and you're compared to another specialist of ordinary and reasonable knowledge, competence, and skills with, as I said, circumstances that are similar. So what is the obligation of mean is to take all the usual means indicated and appropriate. So if a test is not indicated or appropriate, don't do it. It won't change anything. There's another decision, and we'll come, I'll discuss it a bit more later. That is Frias da Costa versus Billick. So that was a patient with a darkened skin who had lipomas that were resected at the Jewish General Hospital. And a good part of the repair was done by residents and also med students. So we'll come to that a bit later. This is from the Court of Appeal of Quebec, so quite high authority. So they again say that there's no obligation of result. And also there's something else, because often we believe that, the judge will be a bit too much sympathetic to the victim, and will they will take their feelings into consideration, but no. So really they should they should use law to decide if you did something wrong, and not only if the victim looks miserable. So if you think this would be taken into consideration, the fact that the patient got really injured and has the public sympathy, it is not a legal argument. So this is on our side. Again, so also the burden of the proof is not on your shoulders, it's on the plaintiff's shoulders. So they have to demonstrate that you have committed a fault, and they have to demonstrate that that fault created an injury to them. And it's by the balance of probability. So what does that mean? It's the 50% plus one. So if it's 50-50, you win. Okay, so the patient needs to have more argument to be more persuasive than you are. and you need to meet, of course, general standard of care. So as I say, it's an obligation of means, and if you promettre, looking for a word, if you promise result to a patient, actually this is against the code of ethics of physician. So never guarantee any results to a patient. Okay, it's only means. So again, going back to le gardeur versus la pointe versus le gardeur. So it's not because you made a mistake that mistake is a fault. Okay, so there's a difference between both of them, and they try to define what is a fault, and they say being unskillful, carelessness, lack of knowledge. So that would be a fault. But if you have proper knowledge and proper skill, and you did a mistake, it is not technically a fault. Okay, so you have the right to make mistakes. So then you have two. So there's like a common practice, but there's a new systematic review that tells you not to do a CT scan. So are you going to do the CT scan or no? So what do you do when you have competing theories or controversial questions? Actually, you should always like do what are called the universally accepted rules of medicine. Okay, but you can go against them only if there is if both theory are equally reasonable and founded on scientific writings. So if you have a very, very strong new evidence that tells you that the previous universally accepted rules of medicine has changed, you must change your practice. Okay. So as long as your practice is grounded on scientific writings that are at least equal to other writings, your practice will be back in a good Quebecois. All right. So as I said, you need to be a prudent, intelligent doctor. So you need a reasonable level of knowledge and competence and skill. If you practice in a tertiary center, it's not the same means that are expected from you compared to if you practice at Lakeshore or up north. There was a decision called Fiocco against De Varenne. And yes, it's the doctor you all think about. So because he was the director of the program of cardiac surgery, the court said that the defendant's conduct as a subspecialist must be assessed against this reality. So you're always compared to the person having your position within your degree of hospital. So if you have access to ECMO and you should use it, well, you should use it. And if you're at Lakeshore and you don't have ECMO, well, it's normal that you don't use it. Okay, all right. Also insight. So it would not be correct with all the evidence gathered by the patient to say with all this evidence that I've gathered through the past weeks or months, you should have known my diagnosis with all of that. Okay, you will be only judged for what kind of evidence was available at the time you took the decisions. Okay, so the court won't use anything that was known after your act to judge the pertinence of your action. So there's another decision, MG versus Pinsonneau, and that was a decision with an obstetrician using forceps against the consent of the patient. So the court has defined the four main obligations of a physician. So the first one is to provide the information necessary for them to make, for the patient to make an informed consent. Second obligation is to make the right diagnosis. Third obligation is to provide the right legal treatment. And the fourth obligation is to respect professional secrecy. I think everybody is scared about not making the right diagnosis or not giving the right treatment, but actually the obligation number one about the consent, this is probably the leading cause of actions against doctors. Okay, so you should be, because if the patient did not have all the information in their mind before giving consent, even if your procedure was well done, if there's a complication, you could be liable for that complication because the patient would not have given their consent. So I think we should more focus on the consent compared to it's like equally important than making right diagnosis and also right treatment, and same thing for professional secrets. So as I said, duty to inform. So we all know the principles of inviolability and integrity of the person that is written in the Civil Code of Quebec. So I will ask you, Anne, again, to please read section 2 of the Civil Code of Quebec.
No one may be made to undergo care of any nature, whether for examination, specimen taking, removal of tissue, treatment, or any other act, except with his consent, except as otherwise provided by law. The consent is subject to no other formal requirement and may be withdrawn at any time, even verbally.
So I'm very curious that we use paper forms for MRIs, and we don't do that much documentations before an LP. And it's not because you use a paper form that the patient really gave proper consent. If they only signed a paper form and they didn't have the information that they needed to know before having the procedure, your paper form doesn't work that much. So it's really it is really the information that the patient had prior to the procedure that has legal value. Same thing for the discharge instructions. The patient signing, leaving against medical advice. If you didn't give any discharge instruction, you could be in trouble. All right, so going back to that lipomas case.
How can you document like it's your word against this one?
We'll come to that in 3 slides. But if you document it, that will be helpful. All right. So the lipoma case, they just say a few things about the general rules for consent. So the consent must be free and enlightened. That's a matter of respect to the person's autonomy. The person must be capable to provide consent, and all pertinent information has to be given to the patient. So in that case, the patient said that nobody told her that there would be some residents and med students. We'll come to that in 2 slides. Also, so what should you say to your patient before a procedure to have proper consent? You should describe the nature of the intervention, if there is any alternative to the intervention, what are the important risks of such intervention, and also if something is done on an elective priority, then your duty to inform is, of course, stronger. So this is the CMP advice because we work in an emergency environment when we don't always have the time to obtain patient consent. So I just want to emphasize that emergency treatments should be limited to those necessary to prevent prolonged suffering or to deal with imminent threats. And as soon as you know what are the wishes of the patient, they must be respected. So this is extremely important. Yes, work in an emergency, but if you're doing an ambulatory care shift and you've been speaking to the patient during 10 hours and you still don't know what are their wishes, you cannot say, it's an emergency, I'm doing what I want. Okay, you still need to obtain patient consent as soon as possible. All right. Yeah, so there was a case, so this is a good example. So Robitaille against Picard. So there was a patient who had a brain tumor, brain mass, sorry. If it was only a meningioma, so the patient said that the goal of the intervention in the OR was only to have a biopsy. And then in a second time, there would be a second OR. And there could be resection if it was not malignant, or there could be chemo if it was malignant. But what happened is that the doctor did the whole procedure and did a complete resection of the mass. And finally, but the doctor did it properly. The only thing is that the patient had a stroke post-op and had a severe impairment after she was in a wheelchair. So again, there was no error in the way to perform the procedure, but the patient said, because I did not give consent, then the doctor should be liable for the complications. So, so how did they decide if she had consent or no? So how did they balance between the patient's version and the doctor version? Well, they looked at the medical notes, okay? And they, because yes, it's a part of the proof. And they write that the notes in the medical file remain important pieces of evidence. There's a probative value. And why does it have a probative value? It's because they are generally written very close to the intervention. So they are a good memory of what happened compared to your testimony 4 years later. Okay, so this is why there's high value to the medical notes. And again, they also write that if something is not written in the medical notes that is normally written, they can presume that it was not performed. It's a presumption. Okay, so you can always reverse it. So if there was 10 nurses listening at your discharge instructions and you forget to write something, all the nurses can say, yes, really, you did it, so you'll be good, okay? But there is a presumption that you did not give the proper instructions if it's not written in the notes. But you don't have to write everything. It's just that if something is normally written and now it is not written, it is presumed to not have been done. So again, a presumption, as we can see in the Civil Code of Quebec, I won't ask you one to read, but can be refuted by proof of the contrary. Again, a court has decided that the notes are clearly preferable compared to the plaintiff's vague memories. And this is a decision, it involves a nurse at the Hôtel Dieu de Lévis, but there was a patient in the ICU in shock. She took the temperature. She noted the temperature in the medical chart. She says that she also took the heart rate and the blood pressure, but she did not write them. So the judge said, I don't really believe that you would write only the temperature if you took really all vital signs. So je prends pour acquis that only what was written in the notes has been done. All right, so let's talk a bit about, because I see that the time flies, about supervision of medical team. So again, this is the lipoma case. So the court said that in tertiary center, such as university hospital, patients tacitly consent to being treated by a multidisciplinary team, and that includes residents and medical students. So this is good for teaching, a very good decision. So what happened in that case, as I said, is that the surgeon has the surgeon, we have more details on the other slide, showed how to do some sutures. The surgeon left the room. There was a surgery fellow with some med students. The med students did the repair. Surgeon went back in the room and repaired 1 or 2 sutures that were not done properly. So the court has decided that there was no fault. Okay. So a physician does not have to be all of the time looking at what you do, as long as there is certain form of supervision according to your level. There's no fault by delegating acts to residents and students. Just the same thing. Okay, so just a quick recap. So for civil liability, we need fault, causal connection, and injury. I'm spending 2 seconds on causal connection, and then we'll move on to injury. So causality, just need to know that it's not causation is not the same as scientific causation. Okay, so there's many kind of evidence that could be taken into account, such as facts, statistics, and also experts' opinion. And at the end of the day, it's the judge that will decide if you're guilty or not a meta-analysis. Damages. So let's say, for example, that the patient was able to prove that you have committed a fault and there was a connection to any injury the patient has suffered. How much will the patient find in that nice wallet? I'm not going to go through that. Just look at the last section, 1616. So damages awarded for injury are eligible in the form of capital. So this is money payable all at once. Okay, so how do we compensate for injuries? We give money. So this is what has been decided, but it's hard to like repair other rights. So what is the patient victim of fault entitled to? 2 things: pecuniary losses. So this is prospective loss of earnings. So this is why obstetricians pays a lot to be member of CMPA, because a young 0-year-old child who is not able to work in his life because he has paralysis, we can evaluate that he would have once, for example, $2 million in his life as a worker, and now he cannot work because of the fault. So this is why babies value a bit more than older person, just based on that part of the prospective loss of earnings. There's also the cost of future care that will be compensated. So if your patient needs a 24/7 care attendant, that will cost you a lot. Okay. And then we have what we call the non-pecuniary losses. So this is everything about reduction in life expectancy, suffering, mental pain. So the question is, how much does that, what is the value of losing joy in life? So there was a case from the Supreme Court of Canada written in 1978, okay, because in the United States, they have trials with juries, and they are giving a lot of money. So there was some surenchère. I'm sorry, I'm not having the English word right now. So the Supreme Court of Canada said there must be some predictability in what a person should be entitled to for loss of joy in life. So that case was, they said, the worst that can happen to anybody. So we're in 1978, okay, context. So 20-year-old male person, young worker at the Canadien National who became quadriplegic after a traffic accident. And there was no SAAC at the moment. So the court has written, I would adopt as the appropriate award in the case of a young adult quadriplegic like Andrews, the amount of, so what do you think was the, what is, and this is actual, what is like the maximum amount someone could have for like loss of life expectancy and joy in life in 1978? What would be the cap? Do you have any idea? 2 million. 200, 1 million, 2 million. All right, so the answer was $100,000. Okay, but that was in 1972. Now this cap with the inflation, and that's based on a 3.25% inflation, is now $350,000 or $400,000. Yes, Armin.
You wrote in the description unmarried. Was that taken into account?
I'm not sure.
Okay.
But they have written it. So in 1978, it's not impossible. I'm not sure of like the point on la balance. So how does it work? For most of the cases, they look at your permanent disability and they will do like a rule of 3. So for example, there was a patient with a knee fracture dislocation with a permanent disability of 24%. The maximum cap was $359,000. So they said 24% of that is $100,000. So this is how they calculated the amount. Same thing, MTBI, they gave 5% of $400,000. And recent in 2015, they said that the cap was $360,000. Just to know, this rule of 3, so taking your permanent disability and multiplying it to the cap, is not always followed. That was the case in Station de la Vallée Saint-Sauveur against MA. I'm almost done, guy. I know it's been a while. So a patient had only a 29% disability. So that was a young child on a ski session who had a very, very bad ski accident, including cardiac arrest of 18-minute cranial fracture, being unconscious for 13 days. But after all of that, the permanent disability was only 29%. But the patient received 90% of the cap. And why is that? It's because the cap is not only like to do a règle de 3 with your permanent disability, it's also there to compensate for like the actual accident you have and all the suffering you went through during your accident. Yeah, this is what I just summarized. All right, vicarious liability. So sometimes there is a doctor, there's a resident, there's a med student, there's a nurse, there's someone who has done the triage. Who's responsible? So as a general rule, Johan, you want to read this one?
The principal is bound to make reparation for injury caused by the fault of his subordinate in the performance of their duties, nevertheless, he retains his remedies against.
All right, so general rule: if you work for someone, that person is responsible for you, except for doctors, because of the Medical Act, they give exclusive right to practice to doctors. So the Court of Appeal said that the hospital cannot be responsible for acts that they cannot do themselves. Okay, so this is why often when there is professional liability involved, the hospital is sued for like triage and nursing care, and also the doctor is on the bench. Now, residence liability, we're paid by the hospital, but we do supervised medical act. So who's in charge to pay for our mistakes? Is it the hospital or is it the staff? So in most of cases, it's the staff, because most of the time we do medical acts. We perform medical acts. So this is what was said in a paper from 2002. There were some exceptions reported in the jurisprudence. At some point, a fellow did a very, very minor procedure. So that was the medical act and there was no mistake. But after the procedure, the fellow forgot to remove the elastic band. So the court said removing this elastic band is not a medical act. So the hospital was responsible. I know it's questionable. And another exception was a junior resident in PACU Green Service. And that resident is now a staff at the Jewish. It's always nice to read decisions and to look at names. And the resident created a severe bleeding when doing a cryo to a patient who was in cardiac arrest post-op. So what the court has said at that moment is that the post-operation, the post-op service was the responsibility of the hospital and not of the surgeon. Okay, but then it has been changed a bit within the years, and they say that whenever a surgeon would be called for any complication, then it becomes the responsibility of the surgeon. But before the surgeon is called, it's the hospital responsibility. It will be his responsibility because he can give instructions over the phone.
Covering ICU consults and you work full. So what's the decision?
Yes. So from my understanding, the staff will be liable as soon as they have the info, or if they should have had the information. And Sophie.
Basically, I call the surgeon, then I go see the hospital.
I'm not sure I get your question.
So this, the surgeon is the person who's gonna be responsible for the post-op complication once he's informed.
Yes.
I'm doing an ICU consult and I get this call. I should call the surgeon, let me be informed. And
If it's a surgical complication, yes. Yes.
like,
But it's a very good question. So if the ICU staff, they kind of take care by themselves of the complication, thinking, for example, it's a sepsis, then it's the ICU who will be responsible. And it might be through the ICU staff. But if it was a surgical complication, you should really call the surgeon so that they can be entitled for their act.
I think the reality of the case is that it's always, and that's what Dr. Tate doesn't answer, it's always case dependent.
Yes, I'll also.
Like you see different cases where the hospital will be responsible because they're responsible for the nurses, and it will be deemed that the nurses didn't do the job properly and letting the doctor know. So every case will be different.
Yes.
So the idea is that the more that you the more you mature in your residency and the older you get, the more you share a part of the responsibility. And as a resident, you're not saying this happened to a patient to your staff, then you start bearing load of the responsibility kind of more. Would you agree with that?
But it's still the staff who would be, yes, will be responsible. But yes, I agree. And my next slide is a bit about that. But thank you for your comment that those are general principles. And the first thing we learn when we attend law school is that there is always a part that is unpredictable when you go in front of a judge, because judges are not computers, okay? And so there's a part that is not completely predictable. Yes.
Like you call a surgeon because that's what we call complication, and the surgeon like if you want to call ICU like and it becomes the ICU's responsibility, doesn't it?
Actually, it would really like depend of the case, and sometimes there is shared responsibility between two doctors. One could be entitled for like 30% of the responsibility, and the other for like 70%. So there is also this. So it's not necessarily 1% is in charge of everything.
Yeah. But they did it right, and then started like imaging. Like technically, that could be a risk of the procedure.
Yes, and yes. Absolutely, but what they said is that it's not a crike that should have been done, but more a tracheostomy. That was a decision of the judge, but yes. Exactly.
decision of making then that was one decision, then that's one thing, but if the lead itself, the one thing.
No, but exactly, you're right. We still need to have a fault. And in that case, doing the cric was considered a fault. I'm not sure why, but yes. All right. So as residents, when can we do medical acts and being protected by our staffs? Well, we need to be in a training site and it needs to meet the objectives of the training period. So this is important. And it also should always be done under the supervision of competent persons. All right, and also, so this is a message for staffs. You should not only look at the level of your resident or student. So M3, M4, PGY2, technically you should not look only at that, but you should look into residents' preparation and global performance when you decide to delegate an act. All right, this is just the same thing. I'll go a bit quicker. Okay, so now just a few minutes about college complaints and disciplinary hearings. Okay, so in that case, so this is done under the Code of Ethics of Physician, and you can be in trouble not because you cause any injury. The only thing that needs to be proven is that you have committed something against the Code of Ethics. Okay, so there's no need for injury. It's only doing something against your obligations that could make you be convened at a disciplinary council. All right, so just 2-3 articles, okay? One is scanning everybody, because we often hear that some person want to scan more people because they feel that they will do less mistake. Actually, this is against section 12 of the Code of Conduct. So a physician must be judicious in his use of the resources dedicated to healthcare. All right, so we have an obligation for that too. Sexual relations, I'm sorry to bring this up, but there are unfortunately a lot of cases. Okay, it's unfortunately very easy to find. And just when I was a med student, I worked with 2 persons who were charged for sexual relations or sexual assaults in front of the Collège des Médecins. Okay, so just to know, you should not be in any kind of relationship with your patient and don't have sexual relation, and don't have improper gestures or remarks of a sexual nature. So one doctor doing a vaginal exam said after the exam, "Thank you for the good time." So please don't say that. This is not a comment that is appropriate. And this is real. This is real. Medical notes. So if a patient asks you, "May I look at my chart?" We always say no. Technically, we should say yes, unless we have good reason not to show them the notes. Okay, and we should always give the notes within 20 days. I know that some hospital will say don't give the chart because we're responsible for like keeping it and bringing it to our chief. So this is why most of the time it like passes through the hospital, but you're free to like do a copy of the medical note and give it to the patient. The secrecy belongs to them, not to you. It's their chart, not yours. Okay, so just keep that in mind. Report colleagues. We don't really do that in medicine. We see this a bit more between lawyers. I don't know why, but if you know that one of your colleagues is incompetent, unfit to practice. So if one of your colleagues is drunk and wants to practice and you don't report your colleague and bad things happen, you are also responsible, because you should have bring to the authorities that they were not competent to work. Just quickly, what sanctions can you have? You can have only a reprimand. You can have temporary permanent striking. You can have a fine also from $2,000 to $62,000. This is normally when you're at your like 15th hearing in front of them. A bit different if it's for sexual relations. There's a 5 years of being off the roll. This is quite new. So the Quebec government really wanted to emphasize that it's not appropriate to have sexual relations with patients. Criminal offense, this is a 2-minute part, I promise. So if you're ever convicted for anything in front of a criminal trial, so it's not the balance of probabilities, it's not looking at if you did any fault. First of all, you have the presumption of innocence, and the facts must be proven beyond a reasonable doubt. Okay, so it's very different from civil trials. Just the same thing that is reported there. Two things that we should be a bit scared as physicians, but don't be too scared, you'll see, is criminal negligence. So by definition, it's an omission of doing something that we have the duty to do. Okay, so we need to take care of our patients. We need to like obtain consent. We need to don't cause injury. And if there is a wanton or reckless disregard in your omission, so for example, there is a cardiac arrest and you decided to take your lunch break, you could be sued for criminal negligence. Really, it is something. Okay, so the burden is like it's so you need an omission of doing something that is your legal duty to do that leads to death, and your conduct will be compared and to like a normal, prudent and diligent physician. But what they will assess is not only that your conduct is different, but it is marked and substantially different from what the other physician would have done. Unlawful act, manslaughter, a bit the same thing, but you do an act that is dangerous and there is death after that. So for example, if you have a very stable patient and you decided to practice open chest and the patient dies, that was a dangerous act, so you could be convicted for unlawful manslaughter. So again, you need to have a marked departure from the standard expected and reasonable person in the circumstances. So I see two examples that could apply to physicians or any other professional is if you don't report youth abuse and the child get killed at home or dies from the abuse, you could technically be responsible because you had a duty to report that abuse. Okay, so be aware. This is not optional reporting abuse. And same thing we'll see for elderly, but it's not elderly protection. Actually, it's a vulnerable patients protection. So any patient who is lodged in a CHSLD or intermediate resource under tutorship, curatorship, or under a mandate of protection, or anybody living in a private senior residence, if you suspect abuse towards those patients, you should report it. So it's the same as for youth protection. And this is quite new.
And this is abuse including negligence towards the person?
Yes. There was a case, only one that I could find, that a physician, or actually that was a PGY 6, pediatric resident, who was convicted for manslaughter and was condemned to 2 years in prison. It was a suspended in pen. So what does that mean is that the resident did not go to jail, but stayed at home with conditions. So what happened is that she was low staff. She was covering 4 different wards. There was a very sick patient, and IT was not functioning that day. There was a very sick patient who arrived, who was in a septic shock, and the resident was a bit reassured by the first blood test, said to the staff that there was a CRP of 60, said to the staff that I think the patient is improving. Patient was transferred to the ward. In the same room as another patient who had a do not resuscitate order. The patient in shock had a cardiac arrest. The fellow, so the PGY 6, arrived in the room, had the resuscitation stop because she thought that the patient in shock and cardiac arrest was the one with the do not resuscitate order. And yes, the patient died. This is a case from the UK, okay? And many experts, because I read 2-3 papers commenting this decision, thinks that it would not apply in Canada. Okay, the burden is quite higher here to be condemned for gross negligence. Okay, so you can sleep more quietly tonight. Okay, but yes, and finally, this resident was able to finish their program and now is practicing. Okay, so it finished well finally. Yes. So yes, exactly. The staff was on call and the staff was not present. Absolutely. The staff was at home, and actually I think the staff was like driving or something like that. So the staff could not go in-house also.
So we got it. It was not.
No, I don't know why, but no. And I think a part of it is because the resident reassured her staff. Said, I think my patient is turning the corner. And also what was very bad with that decision is that after that resident being accused, like her protection organism, the equivalent of the CMPA, told her you should maybe do some reflection work on what happened, or maybe it was the university. I'm not sure of the authority who asked her to like produce some reflection of what happened, and they took that and they put it as evidence against her at the criminal court. That I know it's a very strange decision, and it went in front of the Court of Appeal, and they only commented on the causality, not on the fault. So I'm not sure this would apply here, to be honest. Actually, I'm sure this wouldn't apply here, and there's a lot of comments, the decisions comments that say that this won't apply here. All right, so take-home messages, we're at the end. So physicians have an obligation of means, not result. A proof of an injury is not a basis for presuming that a fault was committed. Proof that a fault was committed does not without more establish the existence of a compensable injury. Notes in a medical chart remain important pieces of evidence, and a physician has to fulfill 4 obligations towards his patient, inform patient and obtain consent, make the right diagnosis, provide right medical treatment, and respect professional secrets. So thank you. I'm ready to have questions if we have time.
We'll have time for one question.
Oops.
I did one question about that last point, that person started the show. And let's say the busy emerge, I don't know, wherever it is in Montreal, and you're clearly overburdened, clearly understaffed, and clearly are not able to get everybody in front of the bathroom. And something happens in the hospital setting like that where you're not made aware of, and you physically weren't able to address them in a timely fashion, and they like sue you for whatever reason.
You're always compared to someone within similar circumstances.
Okay.
I cannot like answer this like that specific question, but yes, it is known that you're always compared to someone in your circumstances. So if you have a patient who has a missed triage, or if you have a very overcrowded emerge, if there is a code orange, of course, the means that are expected from you are not the same compared to like a shift, and you have all of the time to take care of one patient who's not in critical state.
As long as the patient is in the waiting room and you haven't seen him, not under your care,
yeah, it's always a question of being aware of. So if you're aware that there's a cardiac arrest in the waiting room, you should go. Yes.
Question from years ago when I went around, and the first case report, they didn't know the case was case analysis, but the court will take the contact into account.
But there's some stuff that will put that in the chart. Where the note that they will write, seen in the context of COVID pandemic with a surgery capacity,
Have to leave that side because obligation needed point, it's gonna be very soon.
If you don't try the like code surge in your note, you can still prove it, but it's not bad to write it. Yes, if there is any like circumstantial factors that would change your practice, for example, like very aggressive family won't let you touch the patient or something like that, you can write it and it will explain why your conduct was a bit different than what you would have done normally.
A quick comment.
Oh.
This is just to show you also that when you chart, make sure you're charting you well, and mainly your plan at the end of your sheet. Okay, because there's nothing more than a year later trying to figure out patient discharge and home with the indication, and you don't know, and you have to figure out which indication you gave and stuff. So be very specific what you told the patient, you left with room with his mother, were they happy, what you know. So the more you put in your disposition plan at the end, that will help you very a lot. I will tell you that.
Very good comment, and a comment on that comment. What's the most important is what you do and what you say, not only what you write in the chart. It has to be true. Okay. Thank you.
Sorry. Where do I go? Where did I go for my key? Down here? I did. Ah, yes. Thanks, sorry. There you go. Okay.
It's very annoying multiple times.
Is it? Yeah.
Just like the fan.
Okay. Yep. Thanks.
Even if before they like
Okay, hi. My name is Miriam. I'm one of the CCFP EM residents, and I'll be talking about distal radius torus fractures and more specifically the FORCE trial. So I'm sorry for any like ped averse people in the room, but I plan to do a bit of peds in my practice, so I focus a little bit on the topic. Yeah, sorry. I apologize. I'll remove my mask. Okay, so I'm discussing distal radius torus fractures and more specifically the FORCE trial, which was published this year. And for me, it's of interest because I plan to do peds in my practice, but I'm sorry for those who won't be including that in their practice in the future. And my presentation will specifically focus on the different management steps from diagnosis to treatment to follow-up. So distal radius fractures are commonly buccal fractures. So over 50% will be buccal fractures. And this is because compression often causes basically buckling, but no disruption in the cortex. And we see a lot of different fracture types in peds because of the presence of growth plate, but also a spongier bone and immature bone. And another way of naming a buccal fracture is torus, and this really comes from Greek architecture. There's like this round donut-shaped part of the column that also resembles the appearance of a buccal fracture on X-ray. Yes.
I forgot to share the screen on Zoom.
Oh, okay, sorry.
People at home don't see it. Sorry.
Could be helpful. Okay. And essentially, one of the more important steps that we're going to see with the paper is really properly diagnosing a buccal fracture. So I just included the different X-ray findings that you will often have with this type of fracture. So it usually appears like an asymmetry, bulging, or deviation of the cortex without actual disruption in the cortex. And you shouldn't be seeing any angulation, displacement, or rotational abnormalities. You can, however, appreciate some soft tissue swelling with this type of fracture as demonstrated by the arrows in the top image. So the differential diagnosis for this type of fracture are listed here, but you could have a green stick fracture, which would appear with a cortical disruption on one side of the cortex. And this would be treated with rigid immobilization and follow up with ortho in 1 week. Salter-Harris type 2. So if you guys remember the Salter-Harris criteria, that's a fracture above the physis, but also through it. It's usually treated conservatively with the, non-operatively, I should say, but also with rigid immobilization and follow up with your orthopedist in about a week. And as you can see from the image, if you just look at one view, it could sometimes mimic the appearance of a buccal fracture.
And therein lies the importance of always doing your 2 views when you're x-raying anybody. And finally, a minimally displaced complete metaphyseal fracture, which again would be rigid immobilization plus or minus. Sometimes you have to model the fracture if there's a lot of displacement or angulation. And again, it's could appear like a buccal fracture in one view, and that's why you need to look for cortical disruption in a second view. As of right now, there's no national guidelines in either Canada or the United States on how to adequately manage these types of fractures. The NICE guidelines, or NICE, I don't know how you're supposed to say it, have commented on this. I think around 2016, they were saying a bandage or easily removable splint and immediate discharge from the emergency department is appropriate, but this was based on like old trials that weren't properly they weren't sufficiently powered, and so they're not necessarily taken into account in our guidelines. I just copy pasted our local practices. So just next door in the Montreal Children's Hospital, they have this really good EV fracture guideline, and for distal radius buccal fractures, they recommend wrist guards, and they don't specifically comment on any necessary follow-up unless there's any concerns. And they usually recommend no sports for 4 to 6 weeks. For Americans, they don't, again, have any guidelines, but Choosing Widely has commented on maybe the best practice or safest treatment being a removable splint for 3 to 4 weeks, as long as the following conditions are met. I won't go through them all, but essentially the importance is really to confirm that this is a buccal fracture and not another type of fracture. And so the conditions really confirm this the diagnosis essentially. And they don't recommend any cast or to perform follow-up x-rays unless obviously you're concerned for a complication or that the patient's not impaired. And so this kind of thing to no consent management is, and there was a survey that was about years ago actually said that both pediatric orthopedic and pediatric emergers have a very way of managing, but they also they do mostly require follow-up in Canada. And there was a study that was done about 12 years ago that was, as I was kind of saying before, wasn't sufficiently powered to come to any like very meaningful conclusions that could be translated into practice, but they had compared a soft bandage for 4 weeks compared to casting. So like first a back slab for a week and 3 weeks of circumferential casting. And they had seen that pain and functional recovery was pretty similar, except for increased pain in the first week with the soft bandage. And as we can see, like this didn't really translate into our practice. So basically, I'm still asking the same question: how do I appropriately manage a distal radius fracture? And I'm hoping that by talking to you about the Torus trial, which was recently published, that we could maybe all agree that there is maybe room for soft bandage as a way to manage these types of fracture. So the study was designed, it's an RCT equivalence trial that was conducted in 23 emergency departments in the UK. And it was ranging from trauma centers to just district hospitals. And they elected to do an equivalence trial because so far there's no proof that either management option is superior to the other. The inclusion criteria for this study were children aged 4 to 15 with X-ray confirmed distal radius Torus fractures, and they did allow for concomitant ipsilateral ulnar fractures of any type. They excluded patients who had an injury over 36 hours at the time of diagnosis. If there was any cortical disruption on X-ray, which would otherwise mean that this is not a buccal fracture, or if there were any additional fractures outside of the wrist, I think that just means that the patient would definitely need follow-up and therefore couldn't be appropriately randomized to the different interventions. And if the parent or patient couldn't adhere to the follow-up procedures, this could be because they didn't have access to internet, language barrier, etc. The participants, there were about 1,513 people who were deemed eligible. There were a couple of people, like 548 people who declined, and most of the people declined. So over 50% of people declined because they preferred not having a soft bandage and preferred rigid immobilization. And then 89 of them were deemed ineligible because they couldn't adhere to the follow-up. So ultimately 965 people were included and were randomized. So the question is, were they randomized appropriately? And I would say yes, the patients were randomized using an electronic system, 1-to-1 ratio. And this was done stratified by the age group or the site. So they did split the patients in an age group of 4 to 7 and 8 to 15. And were the groups similar at the start of the trial? Again, yes. So if we take a look at the demographics, there were more people included in the 8 to 15 category, but this was reflected in both groups. And there were also more male than females. And again, this is reflected in both intervention groups. Do I think the study population applies to our patient population? I do think it is the case because the UK has a very similar healthcare system and similar patient population demographic as we do. The intervention in question, so for the offer a bandage group, there was a gauze roller bandage that was offered to patients. Whether or not they actually wore the bandage was left to the discretion of the patient and family. They didn't have any planned follow-up, and return to activities was as tolerated. For the rigid immobilization group, a manufactured rigid splint or a back slab or plaster splint was applied in the emergency department, and the decision for which type of rigid immobilization was left to the discretion of the clinician. 95% of people gave a removable splint though, so that should be of note. And the treatment advice was usually given as per the center protocol. Were the participants blinded to the group allocation? So no, they weren't. I think it would be like very difficult to hide an arm from a patient or a family member. So I don't think there's a way to have built this study where patients could be blinded. And were all the groups managed differently, similarly, sorry, except for the intervention they were. So the way that it was done for the follow-up is a validated questionnaire and pediatric pain score was used to measure outcomes, and the data was collected electronically. Patients were contacted at different time points, so at days 1, 3, 7, and weeks 3 and 6 to fill out these forms. And they use the validated tools like the Wand-Baker tool to assess the different outcomes. And were the patients analyzed in the group in which they were randomized? So for the most part, yes, but there were some crossovers. And I think I'll discuss this a little bit later, but they did comment on 11% of people in the offer of bandage group that were switched to the rigid immobilization group, and only 1% switched in the opposite direction. And most of the reasons for that was pain. So people with soft bandages presented with pain, and then this physician would decide to, I guess, escalate the care to rigid immobilization. There weren't very many complications, but they do discuss kind of like return to hospital as a type of complication. And we see that there was a bit more returns to the emergency department with a soft bandage than with the rigid immobilization. The follow-up was complete. About 860 people completed all of the follow-ups at all the timestamps, but there were a few people who didn't actually make it to the 6-week mark. Were the patient outcomes all considered? And so yes, and I'm just going to go over the outcomes of the trial. So the primary outcome was pain on day 3, and there wasn't any statistical difference in the reported pain on day 3. It was on the Wand-Baker scale, it was approximately a 3 for both parties. And the only thing that we see is that on day 1, there was over-reporting of pain in the soft bandage group, but that didn't actually stay throughout the rest of the trial. So we could conclude that pain is not really a big issue in either intervention. The secondary outcomes, so they also looked at functional recovery and quality of life, and there was no statistical difference. They had similar rates of school absences in both groups, and patients with rigid immobilization seemed to be more satisfied with the management on day 1, but this difference was not present by the 6-week mark. And finally, there was increased use of analgesia again on day 1 in the soft bandage group, but this didn't really stick around for the remainder of the timestamps. Yeah. So to conclude, like, do I think that this trial was well done? in order for us to conclude that this is a appropriate management, I think so. So at bottom line, I think using a soft bandage without follow-up for buccal fractures is a reasonable choice. So I think so long as you discuss this with the family members and make sure that they're interested, so include them in the decision-making process. So part of the discussion was, for me, was to see how they concluded the same thing, that this is a reasonable choice, but clearly there's a lot of bias that comes in from the parents on how they think that their child should be managed when they have a fracture. So when you say fracture, I think everyone's mind goes to like, this person needs a cast. And so it might be hard for you to suggest they just need a bandage and they could go home with no further follow-up. So after they did the trial, they kind of made patient handouts to help with this decision-making process so that parents can be more involved in the decision, maybe less worried to go home with kind of not much other than a bandage. They also made a physician handout to help, again, determine if a soft bandage is an appropriate choice. And ultimately, like I told you guys, really, it all comes down to the diagnosis. So that the physician handout basically helps you confirm that it's really a buccal fracture and not any other type of fracture that would require follow-up and rigid immobilization. And the things that I think weren't ideal in this trial is that there was an inability to blind participants. Like I said, there's not really a way to conduct this trial where you could, but it was clear that patient and parents' preference was towards rigid immobilization. And this was seen with kind of over-reporting of pain on the first day, maybe them presenting to the ER a bit more than in the rigid immobilization group, and thus causing more crossover in that group. And finally, there's a bit of an intervention bias that I think all physicians are kind of guilty of. If a patient represents to the emergency department, I think I'm a little bit hoping to offer them more so that they're more, like their expectations are met. So if someone with a soft bandage presented, then I think escalating care to a rigid immobilization was like kind of a natural response. However, like something that we should also comment on is that people who presented to the emergency department in a rigid, with rigid immobilization already, so a wrist guard, even if they were switched to a cast, wouldn't have crossed over. So we do note that the crossover rate from soft to rigid can't be really demonstrated from rigid to rigid. And so there is a bit of a distinction there to be made. So key points, so x-rays should be scrutinized for fracture patterns, other fracture patterns. So you really want to confirm that it's a buccal fracture before you determine your management. And it is appropriate to discharge patients home with soft bandage and no follow-up. And usually there is no need for repeat x-rays unless the patient has a suspected complication or aren't appropriately improving. Yeah. I don't know if anyone has any questions. Yes. Oh.
I don't know if I missed it, but when you say soft bandage, do you mean like an ACE?
Like an ACE.
Like
No, like an ACE. So they considered the removable splints that we often give out here as rigid immobilization.
Yeah, so it seems to me that the main difference, like the only disadvantage of a soft bandage would be that pain in the first day. So why not give a wrist guard first day and like then go move on to the soft bandage without,
Yeah. Well, I think what was interesting is that even the wrist guard, if you give it to them, they don't necessarily kind of have to wear it. So the same thing goes for the soft bandage. Like some people will go home and not really use it at all. And so we don't really know if they had pain because, or it's, I guess what I'm trying to say is that part of all of this is trying to limit resources, and if you're going to give a wrist guard for a one-day use, is it really worth the cost? And it's not clear to me that it is. Yeah. Yes. So yeah, I was kind of rushing through, but essentially they before they built the trial, they had this they met up with, I don't know how, I forget the word, but they basically sat down with parents, and parents just thought it was absolutely unacceptable to offer like nothing. So the trial was initially built like no offer of a soft bandage, you just go home, and just conservative management like analgesia. And then parents thought that was totally unacceptable to not be offered something, so they built it with a soft bandage. But I assume that most people are not actually wearing the soft bandage for the 4-week period. So yes, essentially it's like nothing versus wrist guard.
I've heard that, our result is that it's, fractured as well. So it's just like there to remind them to not hold these down, like, should be arguing whatever he wants, you know, and all again, so I think that's one of the bits, like one purpose. Also, I don't know, maybe I missed that, but do you have any other, studies that, corroborates like that, or?
So
That's kind of have similar findings that would say like, okay, that's enough for us to change our practice.
So there were other studies. The last one was about 12 years ago, and it concluded about the same thing, that pain was maybe the only difference between the two management type. And they weren't like good quality evidence. So that's where this author decided that they would make like a really like sufficiently powered study, good evidence to be able to really transmit this into practice, because it's kind of information that was already floating around. Yeah. Thank you.
All right, so thank you for your attention, and thank you for all. This is what concludes our wonderful first in-person academic half day. People at home, if ever there was any issues, please you can send me an email if there are ways to improve these rounds. If I don't know the questions, maybe some could not be heard or stuff like that, so that we can improve this, because I think most of people here, I guess, appreciate it in person, and we might transition into some sort of hybrid mode in the future. So for those who are invited to the RPC, there is the RPC at 12:30? 12:30. All right, so all right, so we'll see you guys there. It's not in the same place, no?
No,
All right, enjoy the rest of the day.